Welcome. Today we are going to be talking with Dr. Susan Smith. We will be discussing the Framework of Care Caring Behaviors Assurance System. It's also known as CBAS. Dr. Smith and I did a project in Western Scotland that lasted about 6 years, at least so far. We are still working there. And we are going to be discussing how we measured this framework of care and the outcomes that we found it had on both the patient and the employee. So now let's go meet Dr. Susan Smith.
Hi, I'm Dr. Sue Smith from the UK. I own a company called Choice Dynamic International, and my background is over 45 years in healthcare in the National Health Service, both as a nurse, as a midwife, as a public health nurse, as an educator, and a strategic manager. And I came to this work with John through being very interested in the caring science work and the analytics that he was doing.
Just to give a little background on who I am, my name is John Nelson. I am the data analyst and primary researcher for healthcare environment. I have a history of doing bedside nurses for 11 years, and I have left the bedside about 21 years ago, and I have owned Healthcare Environment, which is a survey and data management company that specializes in caring science, job satisfaction, and predictive analytics. And I've worked there for 21 years.
One of my pieces of work that was particularly linked to caring science was when I was commissioned to design a caring behaviours assurance system in Scotland. And one of the key factors that I was incredibly interested in at that time was the impact that our work would be having on both the patient interface and the staff employee interface. And when I came across John's work, I began to realize that he could probably help more than anybody I had met in the past, simply because he gave good analytics in time, not waiting for months for research projects to prove the impact.
The first project that Susan and I worked on together was in Scotland, and we started by creating an instrument to measure caring, and we utilized Watson's theory. And we found, after we had gathered data on about 600 patients, that the Watson theory wasn't a good fit for Western Scotland. And we write about this in our book, Using Predictive Analytics to Improve Healthcare Outcomes. It's chapters 17 and 18 that Susan and I write about this. But we found that Watson's theory wasn't a good fit. Primarily, the feedback provided to us was because the theory was a bit too touchy-feely for that context. So then we tried to use Kristen Swanson's theory of caring, and we again tested about 500 patients to see if that was a good fit, and we found that that also was not a good fit. And so then we looked at the documents that were within the National Health Service of Scotland, the NHS of Scotland, and we found a articulation of what they deemed was caring. And so we utilized that to develop an instrument that was specific for the context of Scotland. And we tested about 1,000 patients, and that one worked very well. Now, what's interesting about this is I have worked in about 46 countries thus far, and I have aggressively tested Watson's theory in 13, and it has fit in 13 countries very nicely, but it did not fit in Scotland. So I found that fascinating. But my point here is, before measuring Susan's CBAS model, Caring Behaviors Assurance System model, I needed to develop instruments that measured caring for that context. So that's where it started. That's where the work that she and I launched doing, and we've been working together now for about about 8 years, and we're about to measure again.
With the with the caring behaviours assurance system that we introduced into Scotland, we were mindful that we wanted to utilise the frontline staff to give us information in terms of their own caring behaviours and that experience by the patients. And so we had some collection methods designed, and we called these the person-centred care quality instrument, and that was an assessment instrument. And within that, we had some methodologies. One was where we observed practice. We engaged in a caring walk. We engaged also in family and patient interviews, manager interviews, and we also assessed paperwork. John's analytics were one of the best that we found to capture the data from each of those assessment methodologies.
So in the person-centered care quality instrument, which we also call the PCQI, in that assessment, during the caring walk, during the interviews, etc., that's a methodology where we're actually able to document that caring behaviors occurred or activities occurred. So we're able to actually measure the operations of caring. So that's very helpful. But for me as an analyst, I want to make sure that that documentation of increasing activity and increasing documentation is also impacting the patient and staff report of a caring environment. So for the patient, we used the caring assessment where they responded to those items from the NHS caring assessment that we developed. And then for the staff, we also used the NHS Scotland items to develop a caring assessment looking at caring for self and caring for the patient as reported by the staff, but we also looked at their job satisfaction. And what we found was there was a correlation between, as those activities were increasing in frequency and documentation, we also found that the experience within care improved for both the patient and the staff. And this was statistically significant. And Susan and I write about this in chapter 17 and 18 in our book, Using Predictive Analytics to Improve Healthcare Outcomes. And it is the first study that I know of where a framework of care had several points of argument for the improvement of caring when CBAS was being implemented or a framework was being implemented, because oftentimes we implement a framework, but we don't have rigorous methods to assert that the outcomes improve because of that framework. And these two chapters that we have written in this book provide a careful and methodical argument of CBAS improves the experience of care from both the patient and staff perspective. So in order for us to ensure that the standard was what we understood the leaders want, and it was sustained in a way that the staff would engage, the one thing that I would do, and I'll let Susan address how she pursued this or ensured this from her operational standpoint, but from a measurement standpoint, it was important that the data resonated with them and told their story. So when I measured the PCQI and I examined in relationship to caring as reported by the staff and the patients, that the feedback or the results made sense. But it was more than just reporting the results. It was taking it to an operational level to show them at the ward level what the successes were and the weaknesses were. So if they had received some education in how to care for colleagues, Susan has something called caring conversations and strategies where the staff actually learn to communicate with one another. When I measure things like relationship with coworkers, with their professional growth, with their engagement with the patient, with their workload or autonomy. So all of these things suggest health of the unit. And when I'm able to describe the ward, there's both their successes and their weaknesses, and it resonates, and they it looks familiar to them, then they get engaged, because then they have buy-in to, this is my story, this isn't the average story of the hospital, this is our unit. So now we're going to be able to talk about objective data on my ward, and then have some discussion about to improve that operationally. Because what they do, we measure about every 2 years, because once they listen to the data, then they have to interpret the data, they have to action plan based on the data, they have to implement, and then you have to give time for that implementation of action to take effect. And that takes about 18 months, all of that. So by the time we measure at 18 to 24 months, then we detect the change. And so this is where from my perspective and in my observation, I see staff become engaged, because it does talk about just their unit. It gives them an opportunity to get out of the subjective discussion to an objective discussion and create action plans that they all get on board.
The exciting work that we did with John's analytics was what I would call in real time, getting real time feedback. So one of the key factors for caring behaviours assurance systems is ownership at every level. And we had a mantra that we said, from bedside to boardroom in a week. So meaning the staff were owning the standards and the changes, and they were seeing the strengths and the weaknesses in their own system. What they were able to see, though, was change happen within that week, meaning if they needed resources to change a standard that wasn't working, they were actually meeting directly at executive level, board level, to acquire an extended budget sometimes to make those changes. And I think this reinforces to staff that change can occur and their action plans were meaningful. And where we needed longer time, then again, John's analytics collected the data over time, and we could prove that some change had changed and some didn't. So I think the summary for me with that is that it's ownership at every level for standards and quality.
So I'd like to just share a story in relationship to what Susan was just talking about. Is when we presented the data, for example, on the cardiology unit, and we write about this in the book. But what we found was there were some low scores between the staff and the physician or the doctor relationships on this cardiology step-down unit. And that was in contrast to the staff medical doctor relationships being very good on the ICU and the intensive care units, the critical care cardiology unit. And so when I presented this to them as an analyst, I don't know the story behind that. That's why it's so important that the staff work with me as the analyst to interpret the data properly so action plans can be made based on the staff interpretation. And what was fascinating to me and what I did not know is those physicians, those medical doctors on the cardiology critical care unit were the same doctors on the cardiology step-down unit. So this was very fascinating to me, that the same physicians were being reported one way in critical care very favorably, but very distressing on the step-down unit. Now, this was a very important finding in our discussion on the step-down unit. Both the staff and the manager of the unit and the ward, the senior charge nurse on that ward as well, we were able to actually present that data. I didn't, they did. They presented that data to the physicians, to the medical doctors, and said, help us understand this. Well, the medical doctors had no idea that there was a difference in how they were interacting with staff. So this was a real learning moment for them, and they were completely unaware. But the strength in utilizing the data, it was a healthful way to present a conversation where it was data rather than subjective. I feel that, or the you thing, that you treat me this way, that kind of thing. Presenting the data, showing the differences from unit to unit, even though it was the same medical doctors. And then they actually said, we would like to change this. So they had a retreat, a time together with the staff, the medical doctors and the staff, and they just got to know one another. And the scores, the follow-up meeting, the follow-up assessment were dramatically improved. I mean, the P level was less than 0.001 because it had improved by threefold. And it was a completely different energy on the second time I came, when after they had this action planning and meeting with the physicians, the medical doctors, and the improvement of the relationship. So that's just one example of how we're able to utilize the data for refinement of caring, getting away from the subjective and utilizing the data for those caring conversations that Susan instructs staff how to use.
The question is around raising the chance of the probability of application of the research findings in practice. And for me, it has to be that the researcher and the organizational change agent or the design person like myself work collectively at the same time together, designing the same applicable tools, if you like, in practice. And at the same time, having a constant cycle of reflection back to the actual people that we're researching. So one of the key factors that John was able to achieve was to give regular feedback to individuals and to teams and to the executive team as the research was ongoing, and not wait until an end point. Because what we found was new actions needed to be taken all the way along the 3 to 4 year cycle that we were working on. You can't afford to wait at the end of the 3 to 4 years for a report, a research report. It's too late then. And usually the organization has moved on. Their systems have changed. Their organizational structures have changed. The leadership named person has usually changed in 3 to 4 years. So I celebrated this work with John on the basis that it was in real time and constant.
The other thing that's important in relationship to measuring the intervention and then identifying actions for practice is you need to make sure that your instruments are tailored for that framework or that intervention. But also, it's important to find ways that you can discover what are the key factors. So I did an analysis, and this also is explained in chapters 17 and 18 of our book. I found that there were 6 elements that were critical for success of CBAS. And I don't remember them all, but I remember a couple of them. And for example, it's important that they have access to their quality champions. And quality champions are like the experts in CBAS. So if staff had access to ask questions about standards of care or something related to the CBAS initiative, that they would get that question answered quickly. That was very important. It was important that the staff knew that the executive team was supportive of this. It was important that the staff understood that their peers were supportive of this. And it was important that they responded to the PCQI on a regular basis. I found that the units that reviewed the framework every 6 months, that were more dedicated to completing that and responding to that, those units did better. So I found that there were certain elements required or important for successful implementation of the framework and subsequent outcomes. But I also found in my analysis that since we studied this over many years, I also was able to see where the peak effect, so to speak, of this was, because there was several layers of leadership within this. Susan has training sessions for the staff, for the quality champions, for the leadership, because leadership is key. So it's a organizational wide implementation. It's not just for the staff, it's for leadership at all levels, for the staff, for the experts, etc. And I found that the improvement or the implementation continued to become more refined until about year 4. And I'm talking about individually. And that, so I call that the peak effect. When is the peak effect of CBAS? And I found that it was at year 4. But what is important in that, and again, Susan has talked about how it's important for the data analyst to work with the person that oversees the program. That helped me inform Susan that at year 4, they should do a refresher course, because they want to continue to sustain and maintain that standard of practice, that standard of the framework. And it's at year 4 that it seems to peak. So that's how research is so important, is to understanding how to maximize the use of that program for outcomes.
The issue of funding for me is I like John. I'm an independent consultant working from an external perspective within the organization. I think the value of our joint presentations at the beginning was that the leaders within the organizations that we've worked in could see the value of the co-joining. So when you're doing a joint presentation to leaders within organizations, you must be clear that there is no bias in this joint activity. And I think that's why we also needed some external validation of the work we were doing together as well. So at the same time, parallel research was also being undertaken while John and I were also doing the same things. Trying to say that although we worked together, we were in 2 different companies, so that we weren't, the bias was taken out because of that.
Right.
And I guess the other issue for me was the other research methodologies that were used at the same time sometimes sometimes demonstrated that the system wasn't working.
What Susan is talking about is a national report that came out that said CBAS did not make a difference. And I know these researchers, they're very good researchers, lots of integrity, but I found that CBAS was making a difference in my own experience of observation, in my own data, but I had not yet published the report on the impact that CBAS made for both patients and staff, because we just hadn't studied it enough yet. Now, this report was national, and it, in my mind, wasn't fair because it was using a sample size of 11 units, and it was using Gaussian mathematics, which basically is it uses the average. So they said that there was really no movement in the mean of the different things that they looked at in the average scores. But what they did report in this report is they said there were a couple units that were very successful at CBAS, and they reported there were a couple units that were not successful at all. And so what I did is I had a very healthy and scientific based conversation with the researchers of this report. They were very professional and high integrity, etc. But what I proposed is that instead of using Gaussian mathematics or the mean, that we use Pareto mathematics. And Pareto mathematics looks at outliers. So I wanted to understand what's the profile of those two units that were very successful, and then what was the profile of those units that were very unsuccessful. And that's how I came up with the 6 factors that I measured in our study. And that was, I've already talked about, is the executive team supportive? Do they have access to their quality champion? Are their peers engaged with the process? So those 6 items are what I measured, because I identified that the 2 units that were successful reported that, and the units that were not successful, the 2 units that were not successful did not report those elements. So I made the judgment that those were success factors. And I found in my research that was true. And this too is written about in chapters 17 and 18. So I'm very pleased to be able to finally be able to publish with Susan and the leaders of the research from this organization in this book, because we provide a multifaceted argument of the impact that CBAS has on outcomes. So but good research takes time, because you have to not just look at a pre-post, you have to really follow it over time to look at the trajectories and the patterns. And we've identified that there's a pattern of improvement when CBAS is implemented. Now, I want to say about the 2 chapters that we wrote, and we have a multifaceted argument of the success of CBAS as it relates to outcomes. That would have not been possible if it were not for the accommodations of the other scientists that did write that report that I did not disagree with. Now, in academia, I mean, that's my world. I live in the world of researchers and academics and people that have developed instruments and do studies. And it can be to present a question about someone else's methodology and that an alternative approach might be used, that can be very difficult, if not impossible. And to be frank, it has to do with ego and lack of openness, for lack of a better word, in a scientific discussion, because that's what science is. It's not about you're right or I'm right. It's more about, let's look at this from multiple ways, so that when we say it made no difference or it did make a difference, that the multiple views strengthen that argument. So when I read that report, I did not agree with it as a scientist. And when I approached my colleagues, they were very open. And that was critical for me to understand how they studied this, so that I could then create another opportunity for a different view using different methods. And switching from Gaussian mathematics to Pareto mathematics helped me see. And there is there's literature on there about when to use Pareto mathematics versus Gaussian mathematics, but that's beyond this conversation here. But I just want to say thank you to those researchers for accommodating that conversation and being true scientists to make sure that what was stated was true or not true. And I did find that in my research that it was not true, that CBAS does make a difference. So that's a very important piece in that. So in summary, it's very important to measure the framework that you are implementing, whether it's caring behaviors assurance system, which we've talked about here, or relationship-based care, plain tree, clinical practice model, patient-centered care. No matter what framework you are implementing, it is important that you measure the outcomes that are proposed to be impacted by that framework, because otherwise you'll just change it in 2 years because there's an argument whether it made a difference or not. But it's important that you have measures that collect data about the interventions that are being used within that program, the facets of that program, the outcomes that that program proposes. And so you're able to have multiple views measurement wise to then create an argument over time that the outcomes have improved and you've connected it directly to the framework. Now, this is not done. Nobody does this. But from a science view, it's important to do this. Otherwise, you'll just keep changing and you'll never know what the success factors were and what the elements are that do not work. And it's important that you then, once you've developed those measures and you measure over time to establish pattern of change, that then you present those results every time you measure to those who are enacting the framework, so they can provide feedback on and help properly interpret the data so that the specific actions for change are taken. And when this is done, this engages staff because it resonates, and when it resonates, they know what to do. So I think that would be in summary of, if you implement a framework of care, you have to create specified measures for that framework, measure over time, evaluate the trends, and have the staff work with you to create action based on the data.
Caring Behaviours Assurance System was an organizational change methodology, and had we have only had one set of research studies to look at in terms of the impact and outcomes, we would have stopped using CBAS at that point. But because we had John's framework of analytics, we were convinced that we should try it again and try it in another country to see if it could be transferred. And we did prove that it could be transferred. And at the moment, the Republic of Ireland is a very good example of that. They did apply the principles, and they are watching the interventions closely and measuring them.